Hello and welcome. Today we will discuss the 4 big papers in critical care published this week for the SCCM conference. The first study is effect of early mobilization on long-term cognitive impairment in critical illness. In this single-center, parallel, randomized controlled trial, patients admitted to the Adult Medical Surgical Intensive Care Unit, were recruited. Inclusion criteria were adult patients, that is aged as greater than or equal to 18 years, who were functionally independent and mechanically ventilated at baseline and within the first 96-hour of mechanical ventilation, and expected to continue for at least 24-hour. Patients were randomly assigned, 1-to-1, via computer-generated permuted balanced block randomization to early physical and occupational therapy, that is early mobilization, or usual care. The primary outcome was cognitive impairment 1 year after hospital discharge, measured with a Montreal Cognitive Assessment. Patients were assessed for cognitive impairment, neuromuscular weakness, institution-free days, functional independence, and quality of life at hospital discharge in 1 year. Analysis was by intention to treat. 1222 patients were screened, 200 were enrolled in each group. The rate of cognitive impairment at 1 year with early mobilization was 24% compared with 43% with usual care, with an absolute difference of -19.2%, p was 0.0043. At 1 year, the intervention group had fewer ICU-acquired weaknesses and higher physical component scores on quality of life testing than did the usual care group. There was no difference in the rates of functional independence or mental component scores. 7 adverse events, hemodynamic changes, 3, arterial catheter removal, 1, rectal tube dislodgement, 1, and respiratory distress, 2, were reported in 6 of 99 patients in the intervention group and in none of the patients in the usual care group. So the conclusion was, early mobilization might be the first known intervention to improve long-term cognitive impairment in ICU survivors after mechanical ventilation. These findings clearly emphasize the importance of avoiding delays in initiating mobilization. However, the increased adverse events in the intervention group warrants further investigation to replicate these findings. The next study is continued enteral nutrition until extubation compared with fasting before extubation in patients in the intensive care unit. Open-label, cluster randomized, parallel group, non-inferiority trial in 22 intensive care units in France. Patients aged 18 years or older were eligible for enrollment if they had received invasive mechanical ventilation for at least 48 hours in the intensive care unit and received prepyloric enteral nutrition for at least 24 hours at the time of extubation decision. Centers were randomly assigned to continued enteral nutrition until extubation or 6 hours fasting with concomitant gastric suctioning before extubation. The primary outcome was extubation failure, composite criteria of reintubation or death, within 7 days after extubation. The non-inferiority margin was set at 10%. Pneumonia within 14 days of extubation was a key secondary endpoint. 1130 patients were enrolled and included in the intention to treat population and 1008 were included in the per-protocol population. In the intention to treat population, extubation failure occurred in 17.2% of patients assigned to receive continued enteral nutrition until extubation versus 17.5% assigned to fasting, meeting the a priori defined non-inferiority criterion in the per-protocol population. Extubation failure occurred in 17.0% patients assigned to receive continued enteral nutrition versus 17.9% assigned to fasting. Pneumonia within 14 days of extubation occurred in 16% patients assigned to receive continued enteral nutrition and 25% assigned to fasting. So to conclude, continued enteral nutrition until extubation in critically ill patients in the intensive care unit was non-inferior to a 6 hours fasting. The next study is effect of non-invasive ventilation after extubation in critically ill patients with obesity in France. It is a multi-center, parallel group, pragmatic randomized controlled trial, conducted in 39 intensive care units in France. Critically ill patients with obesity undergoing extubation they were randomly assigned to either the NIV group or the oxygen therapy group. 2 randomizations were performed. First, randomization to either NIV or oxygen therapy, and second, randomization to either HFNO or standard oxygen, also 1-to-1, which was nested within the first randomization. The primary outcome was treatment failure within 3 days after extubation, a composite of reintubation for mechanical ventilation, switch to the other study treatment, or premature discontinuation of study treatment. Total 1650 patients were screened and 981 were enrolled. Treatment failure occurred in 13.5% of 490 patients in the NIV group and in 26.5% of 491 patients in the oxygen therapy group. Reintubation within 3 days after extubation was similar. It was lower in the NIV group than in the oxygen therapy group in the post-hoc crossover analysis. No severe adverse events were reported. The conclusion was, among critically ill adults with obesity undergoing extubation, the use of NIV was effective to reduce treatment failure within 3 days. Most of the difference in the primary outcome was due to patients in the oxygen therapy group switching to NIV, and more evidence is needed to conclude that an NIV strategy leads to improved patient-centered outcomes. Finally, the CLOVERS trial, that is early restrictive or liberal fluid management for sepsis-induced hypotension. This is a multi-center, randomized, unblinded superiority trial. Adult patients that's age is greater than or equal to 18 years with a suspected or confirmed infection and sepsis-induced hypotension after the administration of is greater than or equal to 1,000 milliliters of intravenous fluid, were eligible. Key exclusion criteria were an elapse of more than 4 hours since the meeting of the criteria for hypotension refractory to the intravenous administration of at least 1,000 milliliters of fluid, an elapse of more than 24 hours since presentation at the hospital, previous receipt of more than 3,000 milliliters of intravenous fluid during this episode. The primary outcome was death from any cause before discharge home by day 90. This is the algorithm to be followed immediately after the randomization. And these are to be followed subsequently. 1560 patients were included in the study. The demographic data shows patients were comparable in both groups. Point to be noted is in both groups patients had received mean 2 liters of fluid prior to randomization. This table shows the difference between the groups in terms of fluid administered and vasopressor given. The primary and other major secondary outcomes were essentially similar in 2 groups. The conclusion was, among patients with sepsis-induced hypotension, the restrictive fluid strategy that was used in this trial did not result in significantly lower or higher mortality before discharge home by day 90 than the liberal fluid strategy. The study has some limitations, these are: fluid administration of 1 to 3 liters was allowed before enrollment. Vasopressors were already in use prior to randomization in both groups, that is in restrictive versus liberal, 21% versus 18%. Protocol amendment done midway. The study was terminated early before attaining sample size. Enrollment was left to physician judgment. No specific strategy was employed for the assessment of volume responsiveness. Some patients in the restrictive group received more fluids than according to protocol. Those in the liberal group received early vasopressors. The results may not apply to subgroups of patients with different comorbidities. The trial was unblinded with the potential for bias. Both groups were protocol-driven, there was no usual care group. Hemodynamic targets were the same for both groups. The study was limited to 24 hours. Patients were in the early phase of sepsis, who presented to the emergency department. The results may not apply to more severely ill patients and later in the course of illness. Thank you.